Hello, everybody. My name is Dr. Samy Allam. I am an Associate Professor of Medicine, founding faculty, and CEO of DextroMedical. Today, I will teach you in 20 minutes how to be an effective clinical educator, an essential skill set that you need to know. If you are a clinician, you need to teach your peers. If you are clinical documentation integrity director, manager, specialist, you need to be able to teach the clinical concepts. And today, we'll be able to dwell a little bit more from the scope of behavioral health, like we spoke the last episode. We'll continue that. We'll talk from the scope of social determinants of health and how to be an effective clinical educator in that matter. In future episodes, we'll talk a little bit more about different subjects, including mental health, physical health, and also different topics pertaining to different organ systems. But today we'll continue the conversation about behavioral health and the behavioral health issues that we see in hospitals. So most people think that, I would say, social determinants of health are about housing, food insecurities, and insurance. That's right and valid. However, teaching that would not bring the clinical rigor it deserves. In other words, the real problem is that we don't know how to teach our peers how mental health and behavioral health issues can change the trajectory of care. Today in this session is not about teaching social determinants of health. It's about teaching you how to teach them so they actually show up in decisions, documentation, and outcomes. This is for clinical educators, clinicians, CDI leaders, healthcare executives who are responsible for translating clinical complexity into action. So why social determinants of health education fails? Oftentimes we see clinicians, advanced care practitioners trying to teach social workers, case managers, try to teach social determinants of health, but unfortunately they fail in teaching it. And it is impacting the clinical care decision. We see extended stays. We see social admissions, repetitive within 30 days. When we see the social determinants of health are often invisible in systems, talking from the hospital treatment plan, from the hospital documentation, from the hospital reporting. Being invisible doesn't mean that it does not exist. On the contrary, it exists and it imposes a lot of impact on the hospitals. So how can we reframe social determinants of health as clinical risk? Today, we'll touch base on 4 points as clinical educators of how to touch base on social determinants of health from different angles that make the topic a little bit more important, bring that rigor in, bring that impact. Number 1, social determinants of health must be taught as a modifier of the disease trajectory. What that means is that educators can shift the learner from listing social factors to explaining how those factors change the clinical outcome. For example, the housing insecurity and how it impacts the readmission risk. We see delayed discharges all the time. For patients that stay in the hospital prolonged days, the hospital get impacted by those inflated charges. Patient is not meeting the inpatient admission criteria, but in the same time, we see the patient continue to stay 30, 40, 50 days, and so on. When we teach each other from that perspective, that is impacting the readmission risk, it can bring more rigor. Food insecurity alters medication adherence, and that's another angle of bringing that to the forefront. Incarceration history can disrupt care continuity and behavioral health follow-up, and that's something that we should take note of. Oftentimes in hospitals, they have incarcerated patients that receive treatment, but oftentimes the social risk, just because they are incarcerated, it boils down to one word: incarceration, when in fact patients that are incarcerated, custodial patients, are having a lot of different social risks being imposed on them due to the access of care issues that they have. So we want to bring that to the forefront as well. The second thing is we want to close what is called by the invisibility loop in behavioral health. While that term is not necessarily well known, I'll bring it to the invisibility loop, and that is that social risk is not elicited. Nobody wake up today and choose that they would have a social risk with them. and go and present to the hospital with that. It is subtle and pervasive in nature. It takes time to foster and it grows over time, and patient has no control on it. Providers does not have control on it. The more we bring it to the forefront, like we said, the more impactful social risk can show. Fragmentation of care happens with social risk. Patients oftentimes that have major depressive disorder. We see on the ICD-10 guidelines, they have the initial visit or recurrent visits or mild, moderate, severe nature, have different codes. And so we want to make sure that we capture that from prior encounter if there is any information about that. And that's very important in a continuity of care. As a provider, you would want to make sure that the patient is not presenting for the first time to your attention, not diagnosed that they have a recurrent episode versus an initial episode. Number 3, the tracking of the treatment effectiveness, for example. We want to make sure that if the patient is being treated for psychosis by a certain medication, that psychosis is documented. If they have features of psychosis, if the features of psychosis is presenting with other documentation of social determinants of health, and also other mental health illness, that the combination of that complexity should be showing in your documentation as well. And the poor outcomes. Oftentimes we may review a patient's prior encounter. Sometimes there will be a poor outcome that is not captured in this encounter, and that may impact this encounter as opposed to the prior encounter as well. So that's point number 2 that I want to bring to your attention today in our discussion is the invisibility loop, how to close those loops, especially when we teach documentation or we show the provider that this is something important that they need to talk about, or we'll talk about those to other healthcare teams. How to bring those social determinants of health from that perspective can be helpful for the treatment. The third part that I want to touch base on is teaching social determinants of health at bedside. When someone types in the notes, they should think from the perspective that not only the presentation, the chief complaint, the medication has been given, but also the continuity of care. What that means, if somebody else, a physician, another physician, or another nurse, or another healthcare team from a different specialty, especially if I'm a consultant on the case reading my notes, would they understand what needed to be done? Is it simple enough for other healthcare team members to understand the issue at hand from the psychological or behavioral health perspective? It's a clinical and ethical act to be simple enough to explain the issue at hand for the other care teams to understand. And for social determinants of health to show the continuity of acts, the continuity of the treatment is very important, because you don't want the curveball, the snowball to curve up into a bigger size at the end of the admission and impose a problem on the discharge decision. We want to be able to act from a preventive medicine perspective. The third thing that I want to touch base on today too is that teaching social determinants of health through documentation. If social factors influence care, they belong in the clinical narrative. And the clinical narrative is sometimes augmented to the SOAP note only, subjective, objective assessment plan. While I understand that this is important, this is how we learn and teach medicine, we should look a little bit, teach beyond the obvious. And what that means is teaching social determinants of health. It is empirical and important to bring those social needs to the clinical narrative, whether this is the area that you should be putting in your clinical decision making, not necessarily only on the social history aspect. So if you needed some social health issues to be treated and addressed, you should bring it to your clinical narrative, and you should be putting a little bit more information about what is the problem, what is being done, at the very least. It is not a clerical work. This is clinical and ethical act. So it is our responsibility to bring the clinical documentation of social determinants of health into the narrative. And in my teachings and in my lectures that I gave before, we did talk with a lot of behavioral health faculties. And what they said in that perspective is that they send the information if needed to the social workers. Well, I do understand that the social workers can help with that since they have the subject matter expertise in this area. I, however, think and you may agree with me, it is important from the clinical narrative perspective to understand and show and teach the continuity of care, the social barriers, and especially if it's impacting the physical health as well. Teaching social determinants of health to leaders is very important, and this is our fourth point in our video today. Executives respond to risk, outcomes, and systematic impact. What that means is, we talked the last time about if an individual presenting to a hospital with a social history of social determinants of health, a problem, a social barrier, difficulty in employment or depression due to marital issues, or social determinants of health due to housing or food insecurity, and they go about and they go get released to the public again. If there is a community that is suffering from the social barriers, that will end up with a society, and that will be a bigger impact on the systematic perspective. And so we want to make sure that we understand that it's not a one-person problem. It's a systematic issue that needs to be dealt with, especially from the throughput perspective, from the hospital readmission perspective, from the health equity and the liability. There is a rule in medicine that says if it is not documented, it didn't happen, but there is another rule too. It says minds don't know what eyes didn't see. So as a clinician, a physician, or a social worker, or a clinical educator, if in our minds we did not assess the patient for social needs, knowing that they have social barriers, we will not look into the medical records and try to look into that drop-down list for that particular social barrier. So we need to assess the patient, to abstract that information and input the information into the medical record. Without that rigor, we will not be able to bring the problem to the forefront. So that is from one side. From the other side is we have an electronic health record issue nationwide. The problem is that electronic health records systems nationwide do not recognize social barriers, do not recognize social risks. And ICD-10 codes and guidelines do not necessarily have the fluidity and granularity, I would say, of bringing those problems to the forefront, especially for inpatient psych placements, for psychiatric consults, for suicide precautions, for intensive case management cases. All these different issues are not really brought to the provider's attention for the forefront. What an intact electronic health record system should do, they should be able to bring all these points, all these problems to the provider forefront, to their attention, to be able to understand the magnitude of that severity of that social case and bring forth the resources and the team effort to be able to help with that. But this is not what's happening right now. And we have done quite a bit of research in that topic and subject. We did look into different patients with different diagnoses like major depressive disorders, bipolar disorders, schizophrenia, substance use dependence. And we looked into their prior psychiatric admission, to their suicide risk indicators, to their social determinants of health, the insecurity, the incarceration history. We looked into their ED utilization time and the comorbid medical complexity. And we found that all these different conditions are really interacting and imposing a big impact on the patient presentation and treatment plan. Unfortunately, it is not brought to the physician's forefront, especially if the patient is presented to this hospital multiple times with the same problem. So we have an opportunity here from a system perspective, especially from the electronic health record perspective, to dwell into all these different variables and bring it to the provider forefront for an action. And so what we built a system that predicts the modeling likelihood of the social consults, and that was matched with all these different social barriers and risks and prior encounters, for example, the prior intoxication, the prior suicidal attempts, prior treatment and impact of the treatment. And our system was able to detect the impact of all these different variables on this encounter, from prior information, current information as well. We have publications that talk about that. In fact, some hospitals in Europe took the impact of our research and were able to dwell a little bit more with different applications. But why am I saying that? Well, we're saying that because we're in a day of age now where a patient should not be viewed only by their chief complaint. They should be viewed by their history of illness, chief complaint, social history, physical comorbidities, and treatments. And all these variables should be taken into the consideration. In future episodes, we'll talk a little bit more about how can we be good educators, but also if you want to continue the conversation about the electronic health record system and our patent, please feel free to contact us at www.DextroMedical.com. Thank you. See you next episode.